I'm Dr.D.Prabhakar, Preventive Interventional Cardiologist. A nice term. I like to call myself a Preventive Interventional Cardiologist. I do interventions, but my passion is actually prevention of heart diseases. I'm from Chennai. I have my own practicing place. We do a lot of research here at Ashwin Clinic. I also do my interventions with Apollo and sit in another hospital called Mehta's Hospital in Chennai. Now, I have a lot of interest in heart failure. In fact, recently we are starting a heart failure registry called the ACERT Heart Registry. We were thrown off balance because of the COVID, so we are getting our app ready to start getting data on that. And what I shall do over the next 20 to 30 minutes is share some of my relationship with heart failure with you. That's what we will do. And what I shall do is make it simple, and what we'll try to do is try to give you a simple case record and then go through a case and see how best we could do with this particular patient. Simple patient, 68-year-old retired gentleman with a generally sedentary lifestyle because of his retired life, recent onset cough, asthenia, dyspnea, and or some kind of a worsening of respiratory symptoms. Today, if you had come, you would have said COVID and probably done a CT scan and screened him for COVID. Obviously, he didn't have a COVID. But his past history is significant. He had a myocardial infarction 3 years back wherein his ejection fraction was 35%. Now he also has got hypertension, hypercholesteremia. He continues to smoke and he's slightly overweight. BMI was about 27. That's what he was. His list of medication when he presented had a bisoprolol of 2.5 milligrams, aspirin 100 milligrams, atorvastatin 40 and ramipril of 5 milligrams per day. So what are we dealing with here? Basically, a 3-year-old myocardial infarction, which is chronic coronary syndrome, heart failure with a reduced ejection fraction of 35%, and in addition, comorbidities seem to be hypertension, dyslipidemia, smoking, and adherence. Now, we will not dwell into the rest of the stories too much because the chronic coronary syndrome is a separate topic along with the dyslipidemia and hypertension management. We will not go too much into that. We'll just suffice to say that he is an atorvastatin, which may not be adequate at this point of time, definitely not adequate, and aspirin for the chronic coronary syndrome. 3-year-old, I think is fair enough to have a single antiplatelet therapy. Now, what are we going to do to this patient? We have seen an ejection fraction of 35%. Now, with the 35% ejection fraction, we should all go back to the classification of heart failure, which I think the best definition was given by the Europeans, and this clearly states that there are 3 types of heart failure with reduced ejection fraction, when the ejection fraction goes less than 40, mid-range when it is between 40 and 50, and preserved ejection fraction when it is more than 50. Now, this mid-range ejection fraction is also now termed as mildly reduced ejection fraction. The reason is it tends to favor the heart failure with reduced ejection fraction more than going towards the preserved ejection fraction. So it seems to be more of a mildly reduced ejection fraction. Now, with this background, if you look at our patient has a heart failure with reduced ejection fraction. Now, how do you manage these patients with reduced ejection fraction? Very simple. The 2016 European guidelines is the most quoted picture on heart failure. Very simply, what happened here was they simply put up these patients and said patients with a symptomatic heart failure with reduced ejection fraction, everybody has to be on an ACE inhibitor or on a beta blocker. What about our patient? There is a beta blocker 2.5 milligram per day, and then there is an ACE inhibitor in the form of ramipril 5 milligram per day. Now, are we doing the right thing? Are we in the correct status? After that, they say you add for an MRA and the heart rate is more than 70, you give him Ivabradine. Now, where is our patient? The last visit our patient made to the hospital was 6 months ago. He's basically not very compliant guy, and he's having a blood pressure of 130/80 and a heart rate of 78. Now, how good are we in our treatment? How much have we achieved? There's somebody who's pressed something in the chat box. Is there anything special there? Okay, fine. So what happens is, we have seen that this is what is happening to this particular patient with a heart rate of 78. Nothing has been done. So where do we go from here now? If you look at the treatments that we have seen so far, the ACE inhibitors and ARBs have a significant reduction in mortality. We are looking at mortality, not symptomatic relief. On top of which, the beta blockers showed improvement and the MRAs have also been shown mortality reduction. What this means is it's not the ACE inhibitors, ARBs and the beta blockers. The MRA should also be there in all patients. Now, interestingly, if you look at this particular picture, you will notice that when the ACE inhibitors and ARBs came in first, the sudden cardiac death was brought down by 20%. Then the beta blockers, when it was added, it further brought it down by 42%. So this is on top of an ACE and ARB. That is the reason why beta blockers have come into this a very big way. Then the MRA was added on top of these two. They had a 19% reduction. That's interesting. It came in 2016. But what is interesting is the army beat all these together, and that seems to be working. This is where we stand right now. So what is the current treatment of ACE inhibitors and ARBs? And where do we stand right now? It's a very interesting registry called the CHAMP registry. And you look at this, there are three colors here, the yellow, the green, and the orange. Now the yellow is the patients with contraindication which have not been given the ACE inhibitor, ARB, ARNI, or let's look at it together, ACE, ARB and ARNI, the beta blockers and the MRAs. The green is the ones who are treated, and the orange ones are the ones without contraindications but not treated. This is strange. Now look at the ACE inhibitor and ARB. Nearly 72% got one of these drugs. 26%, though there was no contraindication, were still not treated. What about beta blockers? Fairly close. 66% were getting it, but 32% was not optimal. They were not getting treated at all. 65% or nearly 2/3 of the patients were not getting an MRA, despite what we saw in the previous slide, a significant 19% additional reduction in sudden cardiac death. Now this is something that we have to bear in mind. Now if you look at it in a slightly different way, how well do we treat? We have seen that 66% are not getting MRA, and the patients are getting ACE inhibitors, ARBs, about 66 and 72%. Beta blockers about 66%. Now how much the dose do they give? Now look at this. The red is less than 50% of the dose, the gray is 50 to 100%, only 100% is the blue. How many of them achieve the full dose? Only about 17% of ARBs, 14% of ARNI, 16% of this more or less same. Beta blockers only in about 27%, and 76% don't get only get an MRA. So the best result seems to be the MRA, quite surprising, but the overall usage of MRA is only 33%. So where are we going at this point of time? We are not doing the right way. Now today we have understood something fantastic in heart failure. This is what we call the management of heart failure in 2020. This is what we call the 4 pillars of survival enhancing medical therapy for heart failure with reduced ejection fraction. If you put a patient on ARNI, the beta blockers, MRA and SGLT2 inhibitors, the mortality reduction in absolute reduction terms is 25%. Never seen so far if you combine these 4. And the number needed to treat over 24 months to save 1 life is going to be just 3.9. I don't think you've heard of 3.9 so far. So this is such a fantastic result, and these are going to be the pillars in the management of heart failure. So all the patients, if you put them on that, your survival is going to be fantastic for these patients. Now let's come back to our patient. We have said enough about how to ideally manage heart patient. Now our patient, when he came to the hospital, his blood pressure was 150/95, heart rate was 110, he was slightly overweight. And look at his enzymes, cardiac troponin was slightly elevated, LDL obviously was elevated with 40 milligrams of atorvastatin. That is what you expect. Now what happens to this patient once he comes to the cardiology? They did a BNP which was 1400, the normal is going to be 35 in an acute state, 100. CPK-MB was not elevated, but troponin was marginally elevated. Now what do you do for these patients? How do we treat these patients? What is going to be a working diagnosis? Now, 2 interesting terms have cropped up. One is whether it's an acute onset of de novo heart failure or a decompensated heart failure. How do you call them? These 2 terms you have to understand a little bit, basically out of more. It's more a question of semantics. Decompensated heart failure, if a patient with chronic stable heart failure deteriorates either suddenly or slowly, it's a decompensated heart failure. De novo heart failure is something like patient who has an acute heart failure as a consequence of an acute event like a myocardial infarction, or a more or less gradual reduction in a dilated cardiomyopathy. So this is going to be a de novo heart failure reduction or a decompensated heart failure. Basically, he's got an ejection fraction of 35%, not very symptomatic. So you could fit it into both categories. Now, how do you manage these patients? So far, we have seen, we made a diagnosis of heart failure, BNP is elevated, and where do we go? Now, one thing is going to be the diuretic therapy. Now, I don't want to go too much into the diuretic therapy. Now, for completion, I just want to tell you a few points about diuretic therapy, which is often missed in the management of heart failure. Now, this is a statement from the European Society of Cardiology, very interesting one, which states that if a patient is not on a loop diuretic, start the patient on a particular dose of diuretic like a 20 or 40 milligrams. It's not that we are taking not on a diuretic. If the patient is already on a loop diuretic at home, you start at nearly 2 times the dose of the 24-hour dose at initial phase. That's important because otherwise the patient is not going to respond already on diuretics. Now, early phase evaluation, at the end of 6 hours, the patient should have an urine output of about more than 100 to 150 ml per hour. Then we have adequate diuresis, and probably you would have to continue IV loop diuretics at 12 hours, or maybe reassess and start at 6 hours. If the response is not adequate, like 100 ml per hour within the first 6 hours, you double the dose of diuretics. Then you assess for the state of diuretics and go. Now, on the second day of admission, persistent congestion, again continue if there is a response. You look at a response of 3 to 4 liters per day. If you don't, then probably you'll have to go to the next level and start going up on the dose again. If you don't work for a resistant patient, you act with multiple drugs. And look at drugs that act at different levels of the loop. Look at thiazide diuretics, combine with either an amiloride or an SGLT2 inhibitor. Try adding metolazone. You add all the drugs, use a combination for treatment of this particular patient. Now, within 24 hours of hospitalization, our patient had a fairly good 3-liter output. And what happened to his blood pressure, which was 150/95, came to 102/68. The heart rate dropped down to about 106. And the BNP from 1400 came down to 850, which is quite good. Now, what do you do at this point? You are interested in a couple of things. One is this patient is having a blood pressure of 102/68. The heart rate is high, and you will definitely like to bring down the heart rate in these group of patients. So what are we going to do? Now, the first obvious thing is this patient has already been on a good beta blocker. So probably why not start a smaller dose of beta blocker in heart failure? The easier stable dose to start is going to be a 1.25 milligram of bisoprolol, which has the best data. And you can start a 1.25 milligrams of bisoprolol in this particular patient. Now you start a bisoprolol 1.25 milligram with a blood pressure of this, heart rate comes down to 98. Now, is there an alternative suggestion? How many of you would be comfortable in starting a beta blocker at a heart rate of a blood pressure of about 105 millimeters of mercury, especially in a patient who is just recovering from an acute heart failure? Now, if that is not the case, what else could you do? We could start Ivabradine. Now, there's a very interesting data on Ivabradine in an acute heart failure. Within the first 24 hours, what happens to these patients? The heart rate from 93 dropped down to 68 over a period of 4 hours and then climbed up to 82. So ultimately, you have a 10 reduction in heart rate. Now, what happens to stroke volume? There is a marginal increase, and ultimately there is a nearly 10 ml increase in the stroke volume also. Now, it's an acute effect of heart failure, which is done in about 10 patients, studied by DiFerrari et al. Came up very old study in 2008. Now, what about clinical effects? There is a very good abstract paper of about 68 patients, wherein after the first 24-hour run-in period, patients with a heart rate of more than 80, Ivabradine was started. Now, what happens is, only 3 patients did not tolerate it, had the dose reduced because they had bradycardia. All others had a significant reduction in heart rate and otherwise no hemodynamic change in the blood pressure. Now, if you're not comfortable, there is enough evidence here to state that even in acute heart failure, you can start using Ivabradine. Now, what were the group of cases? There were patients with valvular heart disease, acute heart failure, myocardial infarction, and cardiomyopathies. All were included in these group of patients. Now, this is not the case in all patients of heart failure. Now, our patient was pretty good, but most of the patients are not like that. The moment you start treatment and the moment you start doing something, the BP just crashes and comes down to a very low blood pressure, or it just keeps fluctuating like this, and most of them are on inotropes. And what inotrope we start? Noradrenaline, we start milrinone, amrinone, depending on what the beta blocker status is of the patient. And when you start giving these patients, what do? How do you give a beta blocker when a patient's heart rate is about 116 and patients on a catecholamine support? Another interesting data also available from Pasculo et al. And this study clearly showed that 57% of patients out of just about 30 patients on catecholamine therapy were started whenever the heart rate was more than 70 on Ivabradine. Now, what happened is no significant hypotension of bradycardia happened. What was the heart rate reduction? 10 beats per minute in 6 hours, 11 beats in 24 hours, and 19 beats per minute at discharge were noticed just with Ivabradine. So you have enough justification in starting the very sick patients and fairly sick patients like our patient with a blood pressure that's about bordering about 100 millimeters of mercury. So I think you have enough evidence alternative to beta blockers if you want to reduce the heart rate. Before we used to say this is not the regular indication, it's not the approved indication, all those things, but it does work. Now this patient, what we did subsequently, we were able to increase the dose of bisoprolol, add an Ivabradine also, and then the heart rate was still hovering around 98, and at the time of discharge on the 7th day, the BP actually started coming up, heart rate started coming down to 78, the BNP also came down, saturation was absolutely fine, patient started improving. Now this heart rate is a big menace in the management of heart failure. Now how does this heart rate work? Now important point is our patient had a heart rate of 78. Is it good? Are you happy? Most of us would be happy with a heart rate of 78 in heart failure discharging at these patients. Now, this elevated heart rate at hospital discharge actually predicts the 1-month rehospitalization rate. Now, look at this group of patients with a heart rate of 40 to 60, heart rate of 60 to 70, and heart rate more than 90. Now, the ideal reference point was 60 to 70. Now, compared to 60 to 70, when the heart rate was more than 90, there was a 26% increase in 1-month rehospitalization. So, mind you, if you are going to discharge a patient with a higher heart rate, thinking that you can increase the dose of beta blockers later, you are subjecting the patient to a risk of rehospitalization for heart failure. What about mortality? Because ultimately that's what is important. He has to live to tell the story. Now, if the heart rate is between 64 and more than compared to less than 64 and more than 80, you notice that there is a 41% increase in 1 year mortality. The best rate here seems to be 58 to 64. So it looks like 60 is the sweet spot. 60 seems to be the working point around which we have to be hovering around whenever you start treating patients with heart failure. Now, this is very, very important. Now, predictor of both together. Now, if you look at the SHIFT trial, which is the largest trial of the Ivabradine, this clearly showed that the risk increases by 16% for every 5 beats per minute increase from 70 to 80, more than 87. So clearly showing lower the heart rate, come towards 60 to 70 seems to be the ideal heart rate to have in these patients with heart failure. Now, what about adding Ivabradine early on? Don't delay too much. Like what we did, we gave an Ivabradine early because the reason we gave was for a different reason. We thought the blood pressure was not holding. What happens if you start adding early on? Now, in the SHIFT trial, the moment you added the beta blocker, within 30 days, there was a 30% reduction in risk of rehospitalization. Now, this seems to be parallel lines going together, in fact, going a little wider apart. And this is very, very clear even up to the end of 3 months. So this seems to be, effect seems to be showing as early as 30 days. This is within 1 month, you notice that there is a difference in the hospitalization heart rates. Now, what about recurrent hospitalizations? First time hospitalized, second time heart failure, because once you get a heart failure, the chance of readmission is going to be repeatedly higher. It doesn't stop with one time. It just keeps happening again and again. First hospitalization, second, third, everywhere Ivabradine addition seems to be reducing, and this seems to be statistically significant. Now, this is favoring Ivabradine if it comes to the left of the bar. Follow-up of this patient, we had put this patient on ACE, IRB or ARNI. I'm not going into the discussion on that. Now, bisoprolol of 5 mg, patient tolerated, Ivabradine of 5 mg twice a day, spironolactone, I put him on that, and also add an SGLT2 in the much closer to the 4 big pillars of management of heart failure. I want to reduce the mortality of my particular patient. Once I put them on this, 1 month post-discharge, heart rate is 68, 2 months again around 65 to 70, 3 months post-discharge, again he is fine. Good hemodynamic compensation, patient seems to be doing pretty well, which is what all of us want to achieve. We don't want our patients to get admitted repeatedly for this. Now, where do we stand in India? Now, the Indian heart failure patients, now this is a paper published by Srinivas Mishra et al., and this showed that the heart rate in a baseline systolic heart failure in India seems to be 96. How good are we? We gave the CHAMP registry, but we seem to be faring much worse. So we should be trying to achieve a heart rate of less than 70. Blood pressure, definitely less than 130, 80. The other targets are all pretty much known. I don't want to go too much about all these other points. Now, can adding Ivabradine early on with beta blocker bring a difference? Now, there is another caveat to this. Now, what happens to the other parameters? Now, if you add a patient on carvedilol to Ivabradine, so combination of carvedilol Ivabradine, there is a nearly 2-fold increase in the exercise capacity. Now, what does it mean? The 6-minute walk test is going to be much better in these group of patients. Now, the 6-minute walk test, what happens is, this is a different study. What happens is, when you give Ivabradine and the 6-minute walk test improves like this, carvedilol improves a little more, but look at the combination, that seems to be coming as much as Ivabradine. Don't ask me why Ivabradine came up here. Probably the reduction in heart rate seems to be the most important point in this particular study. This is the Carveva study. The NYHA class, obviously, when the patient's 6-minute walk test improves, is going to show a significant reduction when you add an Ivabradine to beta blocker. So clearly indicating that conventional treatment of any particular treatment with Ivabradine improves the NYHA class. Now, there is also an improvement in left ventricular ejection fraction. This is surprising. Ivabradine in combination with beta blockers compared to carvedilol or carvedilol beta blocker, again there is a significant improvement in ejection fraction over a period of 5 months. It's not too long. Not only the NYHA class improves, the LV ejection fraction also seems to be showing some kind of an improvement. Now, the NT-proBNP or the BNP levels also come up. So the ejection fraction improves significantly. The BNP levels, which are markers of heart failure, they also improve. And the beta blocker with Ivabradine seems to be working at multiple levels. There have been other studies by Ciccone et al. Also published in International Journal of Cardiology showing that if you add Ivabradine to whatever is the conventional treatment, there is a 2.5 to 2.6% increase in the left ventricular ejection fraction. So there seems to be an overall improvement in the ejection fraction because the heart rate seems to be coming down. There is no mechanism putatively mentioned in this group of patients. Now, this Ivabradine in another study again has shown the same effect. So what I'm trying to tell you by giving so many studies is, I'm not trying to bore you with statistics. I want to show you that it's not an isolated phenomenon. It is clearly shown that improves exercise generation, VO2 and the NT-proBNP. Everything seems to be improving with the Ivabradine. Now, how well is it tolerated? If you get into problem, what happens? Now, ultimately, the symptomatic bradycardia is seen about just about 1%, which is same as what a patient has got with optimal treatment without Ivabradine. There's not much of difference between the conventional treatment and optimal treatment. So the benefits are all there without any significant side effects. Now, how does it work in addition to a beta blocker? Now, the beta blockers take few months to start showing action, whereas the Ivabradine seems to be acting much faster, and within 1 month we showed you that there is going to be a reduction in heart failure hospitalization. Not only that, mortality reduction has also been shown. But what happens is we want to talk by guidelines. When you want to talk by guidelines, there's one word that comes in. Go to the maximum tolerated dose of beta blockers and then start adding Ivabradine. That's what they say. But what happens if you start adding an Ivabradine with any dose of beta blocker? That's a very interesting question that crops up to the mind. So this is the SHIFT study, and a part of it was actually presented in the European Society of Cardiology. So if a patient is receiving beta blocker or not receiving beta blocker, what is going to be the difference? Now, the basic SHIFT study, all of you would remember that on a background therapy, whenever the heart rate was more than 70, whenever you start adding an Ivabradine, there was a significant reduction in the primary endpoints. That is the bottom line of the SHIFT study. That is when the statistical significance started working. Now, what happens is, if you analyze it by the dose of beta blocker given, now no beta blocker, less than 25% of the optimal dose or more than 100% of the optimal dose, this is the lower line. You look at this axis, you're going to be looking at the baseline heart rate from 72 to more than 87. The height shows you the heart rate reduction. Now, whatever be the heart rate, it works. Whatever be the dose of beta blocker, again it works. Now, what is the endpoint we're talking about? Independent of the dose of beta blocker, there is a reduction in heart rate. And how the heart rate works in the SHIFT trial, we have already mentioned that. So clearly what this shows is at whatever level of beta blocker you give, it seems to be working. Now, what happens to a patient who's not on beta blockers? Now, this is the most interesting part that was present in the European Society of Cardiology. Now, patients who are not taking beta blockers, when you look at this, you notice that there is a significant reduction in the primary endpoint, the heart failure hospitalization, cardiovascular mortality, and all-cause mortality. Now, what is this 18 to 32%? That's the most interesting part. 18 is the overall SHIFT study data. Now, 32% is when the patient is not on beta blockers. So somebody who doesn't tolerate beta blockers, not on beta blockers, you add an Ivabradine, the benefit is fantastic. So there is a clear indication that heart rate reduction has a significant say. It is not the beta blockers alone that works. If you don't give beta blockers also, add Ivabradine, the effect seems to be better in terms of heart failure hospitalization, mortality, and all-cause mortality reduction. It's a very, very important message that comes in. Finally, to summarize whatever I have given you over the last about, I don't know how long, but 15 minutes, 20 minutes, 25 minutes, heart rate reduction is an independent prognostic factor in heart failure patients. Your target dose of beta blockers are often not achieved primarily because of the lower pressures that we noticed and the poor tolerability. Some patients have contraindications to beta blockers. Therein, Ivabradine clearly complements the mode of action of beta blockers and reduces the heart rate without affecting the cardiac output and blood pressure. And that is irrespective of the dose of beta blockers as we had seen in the previous slides. Now, patients on a combination therapy experience an improvement in the exercise capacity, better ejection fraction, lower NT-proBNP, and there has been also data in even angina where there is an improvement in the coronary perfusion pressures. We've also clearly shown that there has been a reduction in heart failure hospitalizations and reduction in mortality. I think I have made an enough case for all of you to sit down, make your patient sit in the outpatient department, and before discharge, look at heart rate, which is a very, very important parameter in your prognostication in the management of heart failure. So I think you should look at your patient's heart rate at discharge, document it in your discharge summary, because that is very important. And then when he comes back for follow-up, just a change in heart rate is going to give you that the patient's status is changing, and you'll have to be managing a heart failure. Sweet spot seems to be 60 to 70 ideally, but 60 seems to be working pretty well. With this, I will let you think on whatever is happening. Thank you so much. Thank you everyone for spending some time with me, and thanks for the opportunity. And thank you very, very much. And I'm very happy to stop sharing and probably take questions from all of you at this point of time. Thank you very much. If there are any questions, you can just straight away put it inside. The reason I prevaricated from the initial part, I didn't want to just go ahead and let people just take a discussion on heart failure, because I wanted you to understand that you have to get all the 4 pillars in. Remember the 4 pillars: the ARNI, the beta blockers, the MRAs, and the SGLT2 inhibitors. But you have to go to targets. You have to treat to target, because if you want the best result, you have to get the best of all the drugs. And Ivabradine is a very, very good adjunct, and it does find a place in all the guidelines. And whenever the heart rate is more than 70, you have to start a patient on Ivabradine. Don't try to do it in a much lower heart rate, but you can always adjust the dose. You can come down, and Ivabradine is also available as 5 milligram and 7.5 milligram, and the dose is usually 7.5 milligram or 5 milligram twice a day. Somebody's asked a question. What is that? Is there any difference in quality of original Ivabradine plus the generic Ivabradine? I don't know about this, but I will just give you one quote which I read in Twitter by one of the heart failure specialists in, I think Greg Fanaro put it up in Twitter. He's very active on Twitter. They just looked at all the generics and all the originals in America, and they found out that patients had a 40% reduced action there. I don't know about India. I don't think there is going to be any head-to-head study. I don't think anybody will risk doing all this. But there has been a difference. And they clearly came up and said, if you're going to use the generics because of cost in the United States, you're not treating the patient optimally. And and once that post came up, there are a lot of people, other cardiologists who were subsequently posting and telling that most of these patients are not getting treated optimally, and that they are once they shift over to the originals, they seems to be working pretty well. So that's the only answer. That's the evidence that I have. I don't want to give into that because I clearly don't have that much of an experience on this. But my own experience, I can tell you on only one point. I have had this experience with certain other drugs, like when the rosuvastatin is being used. There are some times where I have noticed that if you use a particular brand, like the original brand, the amount of cholesterol lowering is a little better. It's not only with that. The side effects are more when you use some of the dabigatran, not always. So there is some difference between these, because everybody can't replicate and say, we have the data, because we are also that. It can never be the truth, because the way they make it, the additions, the deletions, there is a difference, but I can't give you a solid answer to that. But this is my experience, and I stand to be corrected. If desired heart rate is achieved, will continuing Ivabradine cause bradycardia? Once your heart rate is achieved, I don't think it is going to produce bradycardia. Anyway, you're going to be monitoring the patient. Monitor the patient, don't let it go down lesser than 50 at any point of time. I would be satisfied with the heart rate hovering around 60, which is what I do. And I monitor blood pressure. In fact, I do an extensive home blood pressure monitoring and a daily weight monitoring for these patients. In fact, we have written a paper on management of heart failure, and this publication came up in Indian Heart Journal about, I think last month's Indian Heart Journal, which came up and said, how do you have a guideline or a protocol for discharge of patients? I'm one of the co-authors for that, which came in Indian Heart Journal last month, and which says pre-ICU to ward, and then at discharge and at follow-up, how do you look at these patients and how do you monitor these patients? If you want, you can go through that, and it's there in Indian Heart Journal. That gives you a very fair estimate on how to monitor these patients also. One important thing that I will also want to state here is, when you follow up patients with heart failure, the first week follow-up, 1 week after discharge is absolutely important. That is the time where you can pick up most of the patients who are going to get re-hospitalized for heart failure. That adjustment of dosage and treating those patients at that particular point is very, very important. So if you are going to achieve something there at 1 week, that's the best thing that could happen to these patients. Answering your question, Dr. Kavita, I think it is continuing Ivabradine. You have to monitor it. It doesn't produce much, but just like we showed in a couple of patients, it does happen, but you have to keep a watch on that. Dr. Ram Paul wanted to ask, can you use Ivabradine in atrial fibrillation? If not, why? Now, what does Ivabradine do? I didn't go into the mechanistics and mechanism of action. Ivabradine actually reduces the IF current. What is this IF current? See, whenever there is automaticity, I don't know whether you remember that pictures where it goes up and comes down, automatically it starts the depolarization absence, and then there is spontaneous diastolic depolarization, and then it starts shooting up again once it crosses threshold values. Now, this is what happens. Now, atrial fibrillation does not have this spontaneous diastolic depolarization and then reaching a threshold and then going for a depolarization action potential does not happen in these group of patients. So what happens is, If you start using Ivabradine, it's not going to work because you don't have this. What you have is a chaotic theory wherein the atrial fibrillation does not have this. In an atrial fibrillation, giving that is not going to work at all. So what happens in atrial fibrillation? You want to control the basic mechanism of this, wherein the other antiarrhythmic drugs seem to be working. This is not an antiarrhythmic drug, it's just a bradycardia producing drug. It acts on cells wherever there is automaticity, and it does not work in atrial fibrillation. In fact, there is a very small data with a little caution on these group of patients, especially with sepsis. Sometimes they say that this can actually increase the propensity for atrial fibrillation very mildly. But it's not been found much in clinical practice, but it can do that. So in atrial fibrillation, no Ivabradine because it's not going to work. You probably use the beta blockers there to control the heart rate. In fact, digoxin is coming up in a very big way. Recently, there has been a paper that was published stating that digoxin can be used in heart failure with atrial fibrillation. And in fact, in that particular study, it beat the beta blockers. This came about 2 months ago. Dr. Kishore, thank you for the wonderful presentation and insights. Oh, I didn't want to do that. Other than heart rate reduction, what are the benefits you look for in Ivabradine? I have clearly mentioned what are the data that is available there. We have data in acute heart failure. We have data in chronic heart failure. In acute heart failure, it brings down the heart rate by nearly 10 within the first 24 hours. So it is there. So one. It also seems to be improving the stroke volume, which should be very beneficial for our patients too. And if you're going to be looking at patients in the long term, like over a period of 1 month, the heart failure hospitalization seems to be coming down. And it also reduces the mortality. Heart rate is related to mortality. Not only that, the mortality reduction has also been shown with Ivabradine. So it seems to be having all the effects that you want in a patient with heart failure. So it's not only once hospitalization for heart failure, recurrent heart failure hospitalizations also we have data, and it has shown that it is important. But ultimately, how does it work? It just has a reduction in the heart rate. It doesn't seem to be having any of those pleiotropic benefits. So what I mean to say is, ultimately, the heart rate seems to be a very, very important factor in this. So for this, I think you should be very, very careful and start treating heart failure very carefully and start treating them adequately. Get the heart rate under control. And if you're not under control, patient is still not stable. You're not treating them adequately. One more word of caution for all of you. We are very scared of using these ACE inhibitors, ARBs and ARNIs in patients with the pressures of about 100 or 110. Don't panic. Now there you don't have to worry because these patients generally have a lower pressure and you can give them a good dose of ARNI. Basically what happens if they tolerate a blood pressure of 85, 90, I have patients on that. If they are not symptomatic and they are tolerating that blood pressure, leave them alone. Don't worry. Don't panic on the blood pressure. Don't look at a figure of 86 or 90. So if they are walking up and about doing everything normally, I leave them on that. I tell them don't worry too much about it. If you're having any symptom, check your blood pressure. The caution that I keep telling them is don't check your blood pressure again and again. And most of the time, we dehydrate the patients by giving plenty of diuretics. Be cautious with that and don't give too much of diuretics. Dr. Sundaram, is there mortality benefit with Ivabradine? I did show you the slide with a little bit of mortality reduction with Ivabradine that is there in the shift data. It is there, and in fact, if your patient cannot tolerate, if you cannot tolerate beta blockers, the mortality benefits are much more. It's much more than patients who are already on beta blockers. Even with beta blockers, it is there. Without beta blockers, the mortality reduction seems to be significantly there. And if I remember the numbers correctly, I think it was something like about 9% with beta blockers and Ivabradine, and it was about 28% in patients who were otherwise on these drugs. All Ivabradine brands are costly. Using beta blockers cost effective with better efficacy. Your opinion? All guidelines everywhere have clearly stated one point. Beta blockers have the best reduction in mortality. Now that is over and above the treatment with ACE inhibitors or ARBs. It's true. Agree, definitely it is there. But if you look at the beta blockers, the recommended beta blockers are going to be bisoprolol, 1, and 2, carvedilol, 3 is going to be metoprolol. And what is the recommended dosage of these drugs? You're supposed to go to 25 mg twice a day of carvedilol, 10 mg of bisoprolol, and 150 mg of metoprolol succinate. Have you used 150 mg of metoprolol succinate? I don't think you would have done. I've used it in some patients when the heart rate became very high and I had difficulty controlling the heart rate, but otherwise I've never used that much of a dose. In heart failure, I've never used. So I prefer to go to either carvedilol or bisoprolol, which seems to be fairly easy and better to titrate also in these group of patients. So that way it is there. Cost effective, yes. Beta blockers are going to be the mainstay of therapy. Remember the 4 pillars I said again and again. I'm telling you because I don't want you guys to miss out on this. Ivabradine is there. It is a player. It has useful beneficial effects. But don't miss the point that you have to be treating all these patients with beta blockers, the ACE inhibitor, the ARNI, beta blocker, ARNI, the MRAs and the SGLT2 inhibitors, which have also shown mortality reduction. So you have to start using these. So it is very, very important there. And I totally agree with you. Ivabradine is still a little more expensive than what is available. Using beta blocker, cost effective, better efficacy. I don't think there's any question to that. But not all patients tolerate beta blockers. There are any number of patients who are not able to tolerate it, and subsequently you will have to probably add up some drug, because the heart rate reduction is ultimately very, very important. So how are you going to achieve that? We have to look at it. Probably we'll have to talk to all the companies, and all of us have to go on strike and get them to reduce the price. Cost is an issue. Definitely it's an issue. But everything has got a price to pay that we have to understand. What duration of treatment regime would you recommend for Ivabradine? I don't think there is a duration of treatment for Ivabradine, because if you're I'll tell you this particular patient. He had a heart rate of about 98, 100 and landed up at 68, and he continues to take 5 milligram twice a day. Now, what exactly happened was, when the dose of beta blocker was increased from 5 to 10 milligrams of bisoprolol, he wouldn't tolerate it. He started getting giddiness because the blood pressure drops because of the hemodynamic compromise, which did not happen with Ivabradine. But when you added the Ivabradine, this is not happening. The blood pressure doesn't fall. So it is a very useful adjunct whenever the BP starts falling. And the other thing is, like I said, the hypovolemia in terms of diuretics. We are pretty scared to stop the diuretics. In fact, you'll be surprised. I don't give my patients routine diuretics at all. I tell them to monitor weight every day and then follow the weight, which is more important, I think, than the diuretics. And fluid restriction is going to be balanced by the patient's weight, and the diuretics is also going to be balanced by the patient's weight. Routine diuretics is questionable, and fluid restriction is also becoming controversial today. The article that I posted on the European Society of Cardiology about the diuretics in the initial part of my talk would interest you. I think probably you can go up and read about the diuretics and fluid status in these patients. There is no duration if you give a right answer for that. Target heart rate in heart failure patients, less than 70 is definitely ideal. Probably around 60 is going to be the best, and possibly we'll have to be looking at less than, let's say, less than about 70 is going to be definitely a yes. Probably around 60, 55 to 60, 65 seems to be the good heart rate. Dr. Manisundaram doesn't have anything to say. Sudhakar has got nothing. Good. Any other questions? I think I've answered most of the questions here. Or did I miss out on anything? No, I don't think I missed anything. Was there anything missed out? Other than heart rate reduction is also answered. So I don't know. Maybe I should remove all these questions. All right. Anything else left? Dr. Swaminathan said, answering all the questions. Thank you. That's okay. I think I'm supposed to answer. If I give you something, actually, I don't know how many of you look at delivering lectures and talks. Probably this is about 80 or 85 of my talks that I've given during the COVID season. When I started my first talk, it was actually before the lockdown. So I had to go for a meeting in Calcutta, and that's when COVID was starting. And I said those people that I'm not coming into Kolkata. I don't want to fly in an aircraft. So they said, okay, we'll start, and that's when the first webinar I gave. And it turned out to be pretty good. Like the response was good. The chairpersons were able to ask questions, and once I started doing that, it was really interesting. And afterwards, it's just been a question of more and more talks and just going on and on. And sometimes you start wondering, when is this going to end? It's just going on. But I got used to it. The time has been spent usefully. I've sent in about 3 publications, written about 4-5 chapters in books. We have come up with about 2 guidelines coming up right now. In fact, we're writing a guideline on anticoagulation therapy for COVID-19 patients from the government of Tamil Nadu. I'm sitting with them. I'm not in government service, but I sit outside and write for them. A lot of interesting work. You have some time for a lot of things, interesting things. I think if you're all going to utilize your time optimally, you're not going to feel bored like the public. You see, in Chennai, when I go outside my clinic, what I see is that people walking around happily, enjoying life. Now that Diwali coming, everybody is kind of off masks and just shopping. My intensivist called me, saw the message for this meeting and said, sir, I'm doing Diwali shopping. I cannot attend the meeting today. That's the status today. Right, somebody has asked one more question, 2 more things. Medical management of angina, many anti-anginal drugs are available. Which is better in your clinical experience? This is a very, very interesting question. I could have done that. we focus on heart failure. I wish we had spoken on chronic stable angina. Now, in chronic stable angina management, there are two groups of drugs that you use for treatment. One is the drugs that produce symptomatic relief only, and two is a group of drugs that are long-term given for mortality benefits. Now, first I will tell you what are the drugs with mortality benefits in chronic stable angina. Only 3 drugs are useful in mortality reduction. One is the antiplatelet aspirin, 2 is the statin, and third one, guess, the ACE inhibitors and ARBs. Beta blockers don't fit in there. All the other drugs do not have mortality reduction, do not have survival benefits, and what you do is all the other drugs that are used are only for symptomatic relief. Interesting, surprising. Now, what drugs are we talking about? We're talking about beta blockers. Beta blockers reduce mortality only when there is additional heart failure. Otherwise, they don't reduce mortality. So, in chronic stable angina, it does not reduce mortality. So, beta blockers, calcium channel blockers, nitrates, ivabradine, nicorandil, trimetazidine, ranolazine, all these 7 drugs can be used at your choice. Now today, there is a 2-3 years ago, there was a very interesting article by Roberto Ferrari talking about the diamond approach for the management of chronic stable angina. Now what was interesting in that was, he said, apart from these 3 groups of drugs that reduce the mortality, those are the 3 drugs, which is the aspirin, statin, and the ACE inhibitor, the ARB, the RAS inhibition. What you need to do is select the horse for course. There is no difference between, it's not that all patients should be on a nitrate. It's not that all patients should be on a nicorandil or a trimetazidine. You just choose the patient based on the clinical hemodynamic scenario. Like if the blood pressure is high, heart rate is high, use a beta blocker. Heart rate is high, blood pressure is low, probably use ivabradine. If the heart rate is high, persistently, ivabradine, beta blocker, combine. But use with caution. But do not combine calcium channel blockers with ivabradine, because what could happen is there could be a sinus pause and significantly problems can happen. So this has to be used with caution. Depending on your clinical scenario, if a patient has got heart failure with angina, yes, you have to use a beta blocker, you have to use an ACE inhibitor or an ARB, and also you're not going to use in atrial fibrillation. Heart rate is low, don't use beta blockers or ivabradine. So depending on the case, you use any of these drugs. So your answer to your question, medical management of angina, which anti-anginal drug depends on your horse, your patient. Your patient, depending on the hemodynamics and the comorbidities, what happens, you have to start treating these patients. So there is nothing like standard, everybody should be on nitrates. In fact, my nitrate usage is hardly there. What I keep telling is, you treat them with anti-anginals, give them a good heart rate control. Once you have done that, give them a nitrate on a need-only basis. If my patient walks for 20 minutes, I stop the nitrates. Give them a sorbitrate tablet. There is an instant sorbitrate that is available. Give them a sorbitrate instant and ask them to keep it in their pocket and take it only if necessary. It works very effectively. This is how I treat my chronic stable angina patients. If it doesn't work still, and if they're not able to do that, best thing, take them to the cath lab, do an angioplasty. Because you're going to give them symptomatic relief. Now, I don't want to dwell into the ischemia trial. Please don't go into the controversy of the ischemia, but this is how I treat my patients. Finally, I had a very good, interesting thing. I think it's probably trying to say bye-bye, Dr. Venugopal. That's a very good message you gave in the end. Clearly stating, thank you very much and happy Diwali. I think I should also put an end to the discussion. If there are no further questions, anything else from the hosts, I think I should thank the sponsors for giving me an opportunity to share my views. I don't know what they had in mind, but whenever I talk, I like to talk about what I read, and I think others should learn from what I read. If the person who benefits most in a talk is the speaker, not the audience, because I read more than you. That's the only way, and that's how I've kept in touch with medicine, staying out of a teaching hospital. Thank you very much for the patient listening, and wishing you all. There's one more question. Let me look at this. While treating angina and heart failure patients, what is your preference, doctor? Do you rely on original ivabradine or generics? We took this question earlier. Dr. Manisundaram is pretty persistent on trying to figure out the generics and this thing. Now the point is, one of the biggest things that happens is that your preference for treatment of angina, like I said, and heart failure, definitely all the drugs with maximum tolerated dose. Heart rate reduction is important, try to get it around 70. Between generics and the original brands, I generally tend to use the original brands, because what like I said, I have noticed some difference between these drugs. But it does not always happen. There could be sometimes cost-related issues. Sometimes if there are no cost-related issues, definitely I'll go for the original. Because what happened was, I don't want to name a brand. There was one original brand which was 75 rupees. And once it went off patent, the price came down to about 15 to 20, 25 rupees. The original brand was smart enough to bring down the price to 30 rupees from 75 rupees. Now, if they do that, you get the best. Your patient gets the best of both worlds. You get a very good original brand and the patient gets a benefit. And the advantage of that is that you are sure about the efficacy of the drug because this is the same drug that was used in the trials. The others, sometimes they fall short because they do just bioequivalent studies and not the clinical efficacy. I have always noticed this. I have always noticed that there has been some difference because most of the patients respond, but there is always a select few where you're worried, you're scared. You ask any interventional cardiologist, whenever they want to give Ivabradine, not the Ivabradine, I'm sorry, the clopidogrel, when there was no other drug available, only clopidogrel was available, at least for the first 1 month, everybody used to put only the original brand of clopidogrel. Reason is you're scared. If your patient comes back with a stent thrombosis, what happens? It was a very, very big issue. So we were scared and we were going for a original clopidogrel. Like that, sometimes we are maybe sentimental, may not be the truth, but you don't want to take a chance in that case. Heart failure is one such instance. Because if you're going to miss the patient, he's going to land up with heart failure. His cost is going to be much more. One hospitalization is going to cost him much more. So I think look at it. Don't try to be penny wise and pound foolish. I think you should be a little more careful there. And I will definitely say that you guys have to exercise a lot of caution and try to work out in such a way that your patients are going to get the benefits. So if your heart rate is good, it's good. But sometimes, like I said, change and shift does work. I think Dr. Meenakshi Sundaram should us close to shop. Anybody else? I think we are done with the whole thing. And thanks to all the attendees. Thank you very much. It was a pleasure having such good number of questions, and it was nice for to all of you. Thank you so much for joining in and spending an afternoon with me. And thanks to the sponsors also for giving me an opportunity and excellent discussion. Thank you very much. And thanks to Surya also for this opportunity. Thank you very much. And I think we will sign out, and I think we'll call the meeting to a close. Thank you so much. Happy Diwali to all of you. Enjoy yourself. Have a safe Diwali also. Be careful and please wear a mask. It's going to save you from not only from COVID, it's also save you from the smoke that keeps coming up. All the best. Somebody raised his hand. Who's Dr. Yadav? Find out what he wants. Well, I think he was probably trying to figure out what is happening. Right, ladies and gentlemen, thank you very much. How do I get out of this?